We've got first Ms. Shamsia for the presentation around East London stop smoking services. And I think you've got a colleague with you, so sorry, I haven't done an introduction. But if you want to introduce yourselves and talk through your presentation.
Thank you, Sterling and Emma. I'm Shamsia Begum. I'm the Stop Smoking Service Manager within Queen Mary for 3 London boroughs, and I'm joined by Janvi Manohar, who's our stop smoking practitioner. Sorry, I've started coughing as soon as I unmuted myself. So we're going to take you through our presentation, and I do apologise, it might be very long. Are you able to see my screen? There might be a bit of a lag.
We can see that, Shamsia.
Okay, and can you see it, the next slide?
Yep, let's click through.
Okay, good, so that's working. Okay, so we were asked by Emma sort of what makes a good stop smoking service, I think. So I had a sort of a clash with another meeting today, so Janvi and I put something together just to give you a big whistle-stop tour of what we do in our stop smoking services. So an overview of all the services that we have within Queen Mary, who we are and what we do, examples of some key activities that we do and the successful outcomes from these activities. And so as we go along, you'll see, examples of the good work that we do. So who are we? Queen Mary University of London is a higher education institute. And according to our president, we are genuinely a world-leading research centre. We're ranked 14th in the world for quality and research, and according to the Times Higher Education, we're 7th in the UK for Research Excellence Framework. So we've been delivering tobacco cessation now for 25 years. I started as a researcher in smokeless tobacco, and now I'm managing services and training stop smoking advisors to deliver an excellent service throughout our 3 services. And we have clinical supervision that is provided by Professor Peter Hayek, who's Professor of Clinical Psychology, and some of you will know him as one of the sort of the leading trainers and researchers in tobacco cessation over the years. Now, Queen Mary is commissioned to provide 3 specialist tobacco cessation services. Tower Hamlets is the specialist service that we've had for 25 years, and the current service that we now have has expanded from something that was very, very small. 15 years ago, we had 500 people that we supported to give up smoking. Now we have 1,500 people annually that have to quit smoking as one of our targets. In addition to this new contract that we have with Tower Hamlets, we have 14 local community pharmacies that Queen Mary subcontracts. So this provides contribution to the whole 1,500 quit outcomes that we have annually. The Newham specialist service, we took over in 2021 during COVID. They had a pharmacy service, but they didn't have a specialist service. So we kind of sort of built that from scratch, taking learning from Tower Hamlets and putting in place a service that would be able to provide a specialist service for all the population groups in Newham. And then Waltham Forest, we were commissioned in September of 2021, again, sort of partial COVID, to provide a specialist service. Now, this wasn't from scratch, but it was taken over from a previous provider. And so that was a very interesting sort of experience in sort of taking over a service that was already running and sort of delivering it sort of in the way that we thought it would fit within the evidence base and the targets and expectations that we had from the local authorities. So the Stop Smoking Service team is based within Queen Mary under the School of Medicine and Dentistry. And then again, we sit under the Wolfson Institute for Population Health and the Centre for Public Health and Policy. Within the centre, there are 4 units, and we're one of the units that delivers health and lifestyle research and health and lifestyle services. So alongside smoking cessation, we have the weight management programme in Tower Hamlets. The smoking cessation staff and myself, we sit with research health psychologists. Sorry. Sorry, Siri decided to jump in there. So we sit with research health psychologists, and the stop smoking service recruitment and delivery that we do also feeds into some of the research that is ongoing at the moment. So previous research was around sort of NRT use alongside electronic cigarettes, and then we've got electronic cigarettes and use with pregnant smokers. So those are some of the things that are going on at the moment. I think we've published a couple of clinical trials that then informs service delivery nationally around pregnant women using electronic cigarettes as a cessation aid. Electronic cigarettes compared to NRT, we found that they're very effective, if not better than using NRT. So our team sits within this unit that delivers health and lifestyle services, and we've been sort of part of this group for a very, very long time. Now, as a service, obviously, we are part of the government's tobacco control strategy towards a smoke-free generation and its tobacco control plan for England. We are also a small part of the NHS long-term plan. Stop Smoking Services are part of the vision for Smoke-Free 2030, working alongside other providers, health and social care. So it's important to understand the national challenge and the vision that we have. And then going into local context, so research and understanding within the local context that we have at grassroots level and what we do on the ground. So in terms of treatment program and behavioural support, we know that the first choice for stopping smoking is with a combination of specialist support and medication or e-cigarettes. So that's like the gold standard. Then we know that the use of nicotine replacement therapy and behavioural support for nicotine dependency doubles the chances of quitting. So, you know, you're looking at 50 to 70% chances of increasing likelihood of quitting. Then as we go into sort of deeper into our local authorities, identifying local needs. So looking at the key performance indicators and targets, local needs assessments, within the public health strategy for each borough around smoking and tobacco use. For example, in Newham, we have the 50 steps to a healthier borough, and we have the Smoke-Free Alliance. So we have a sort of a governance and quality outcome partnership where we can deliver our service with other partners and stakeholders, sort of identifying where key target groups are and, you know, informing our campaigns. So understanding your local numbers, data, target population, smoking prevalence, and then tailoring behavioural support with cultural sensitivity, trying out holistic approaches, supporting clients through their quit attempt, through very different, life experiences. So every single smoker is different, and we are targeting and helping people that are highly dependent smokers through, hospital appointments that they have, or maybe going through illness, and they have to quit smoking, or, smokeless tobacco. So we're helping people with very different situations, and so tailoring the behavioural support to that, providing cultural sensitivity, language support, offering gender support to, ladies that might want to see a female advisor, for example, and then obviously sending people off to other services that might help them, like talking therapies or benefits advice. So, as we say, making every contact count with our appointments. And then targeted partnership work with local stakeholders, so partnerships with the local hospital trusts, substance misuse organisations, who's out there, who's in health and social care that we could collaborate with, that will help us reach our targets. And then finally, it's data, and data. How you manage your data. Do you have effective systems that will manage the registrations from referral to quit outcome to be able to give you monitoring reports at the end that will help help you do audits, equity audits, and target specific areas where you need to see improvements. So we use two databases or data management systems: Farm Outcome by EMIS and Quit Manager, delivered by Bionicle. Also, obviously, it's about tobacco products, tobacco dependency. So these are the local products that we've identified in our boroughs that people are likely to use alongside smoking cigarettes. So there's smokeless tobacco. So these are some of the examples of smokeless tobacco that is available locally and within our sort of communities. So I won't go into the different products. I'll just leave that picture there for you, and we'll share the PowerPoints later. Now, the treatment program that we cover over the three boroughs, it's 8 to 12-week treatments and behavioural support. It's flexible, so we're offering one-to-one telephone support, face-to-face, video calls. We provide 8 weeks in Tower Hamlets and 12 weeks support in New and Waltham Forest based on service specifications. The specialist teams in all three, there are specialist teams in all three, with Tower Hamlets having community pharmacies which are under Queen Mary. All of our treatment program is free, free nicotine replacement therapy, and obviously now we've got the swap to stop electronic cigarettes provided by the government. We are starting to prescribe cytosine in July. We have our own in-house doctor that is able to prescribe and screen patients for cytosine, and that will cover all three of our boroughs. We provide electronic cigarettes as a harm reduction aid, a stop smoking aid. We've been doing this since 2018. We've delivered electronic cigarettes in Tower Hamlets for a very long time, and we've piloted with direct access to smokers through our website, enabling people to access e-cigarettes directly, and then we recruit them into the service. And this is something that we've used with the swap to stop. The Waltham Forest is the borough that we had less experience with in terms of delivering electronic cigarettes. We didn't see a very high uptake, but I will report some improvements further along in the presentation. We do weekly carbon monoxide testing to determine non-smoker status. However, as with other services nationally, we are struggling to reach 85% CO monitoring. However, we have internal targets to ensure that this number goes up. So it varies within our boroughs according to different quarters. So we're increasing our face-to-face appointments to do this. We have a quit rate of around 60% or more as a service provider with all three of our boroughs. So we try to hit 60% consistently. With Tower Hamlets, we've been very, very successful. With Newham, we've increased, and with Waltham Forest, we're also increasing with our sort of target rates and outcomes. Now, locally, as I said, we have to look at the local context and the target groups. So these are roughly all of our priority groups that we cover within North East London, and it's very much people with high nicotine dependency, or people that are high risk and need to stop smoking. So people with underlying health conditions, COPD and cardiovascular disease. And then you've got people from different ethnic groups, particularly Eastern European, who are more likely to smoke, and particularly Bangladeshi community and men smoke more. So looking at these, different groups and seeing what the prevalence is also helps inform the way the service targets different groups. Mental health and severe mental health. Now, this is a target group that everybody's trying to sort of support with regards to smoking cessation, and also, other services that they need to access. So they're one of our priority groups with the swap to stop, and also with the government's additional funding into the services. So we're doing sort of very sort of targeted approaches with these particular groups. We've got routine and manual workers who are more, who have a higher prevalence of smoking, and obviously the 3 boroughs that we cover have wards that are have high levels of deprivation. Now, we've got various sort of different situations with young people within the boroughs that we work with. So in Tower Hamlets, we work with young people under 25 and over 12 to give up smoking as a particular cohort, whereas in Waltham Forest, we're looking at young people 12 to 15 in particular. And then in Newham, we have a very big sort of concern around young people and vape use with nicotine. So that's where the service can come in and support young people who use nicotine in vapes to give up smoking, but in partnership with a local substance misuse service that has a young people's team. So we know that men smoke more than women and are less likely to access the services. So this is one of our target groups: pregnant smokers and their partners and family. And then you have patients in acute settings and people who have previously tried and failed to quit on 2 or more occasions. So a rough overview of all our priority groups that we need to see in the service. Now I'm going to pass over to Janvi to explain the 28-day vape challenge model that we used with Swap to Stop to give people direct access to the vapes. Now, why we try to do direct access is that we were very ambitious in our expression of interest with the Swap to Stop. We've earmarked 10,000 vapes for 24-25 to basically contribute to 1 million smokers switching to vapes and quitting, and also contribute to smoke-free 2030. So overall it was 18,000, but we've, for this financial year it's 10,000. So we're looking at innovative ways to get people access. So Janvi, over to you.
Yes, hello everyone. So as Shamsia mentioned, we've previously piloted this offer in the last 2 years, just borough specific. This is the first time we're doing. We have this offer in all 3 boroughs. So how it works is, so we have a web access link, as she mentioned, which is available through a QR code, which we have advertised on pamphlets, on advertising screens. Again, we use these pamphlets during our campaigns or the outreach events that we hold at, say, libraries outside hospitals. So people can access this link, which opens up to a questionnaire where they need to input their information, basic demographics. It also includes them. It needs them to put in a quit date, so meaning they are signing up, so they understand that they're signing up to a actual service where they will be followed up by an advisor, and they will essentially have to set up a quit date for it, mention any medical conditions they have, just so we can check as well if there are any medical conditions that we cannot give a vape for, like say COPD or emphysema, or if they're using an oxygen cylinder at home. So those are some of the details. Along with that, we also put in questions from the Fagerstorm scale to estimate the dependence that they have as well. And it sometimes, because they fill it, it also forms as a scale for them to estimate, to answer those questions themselves. And at the end, and after all of that, these details go straight to Queen Mary and also to UK eSig. So UK eSig is the company from whom we get now we're trialing the e-cigarettes from. So we have the WICO 1 kit. So a 1 week kit directly goes to the people who fill out the form. All of this is after an age verification, which UK eSig does from their side. After they receive the e-cigarette, these details which go to Queen Mary, we have an admin team wherein we have an admin for each borough. So we have a 72-hour triage system wherein we call up the client who've signed up to the service and set up an appointment for them with an advisor. So this will be done within 72 hours, and following that, the advisor will pick up and kind of set up further appointments with them, discuss ways to quit, ways to use the e-cigarette, ensuring that it's not something that they replace with the cigarette, but they just use as a stop smoking aid specifically. We also keep in mind that that it's not another habit that we're passing on to them, and inform them of the program. So meaning it can be an 8-week or a 12-week program depending on the borough, and also that we will be leveling down on the nicotine strength that we give. So even if we start off with a 2% nicotine, we will be, after 4 weeks, say we will be leveling you down to a 1% and then further down to a 0% as well. And after that, if they wish to quit, even the 0%, we can either switch them to a very low dose patch, or just quit vaping as well along with that. In between these calls and during the first week 1 call, with the advisor, we also check medical history from our side, meaning if there's anything that hasn't been reported by the patient in the questionnaire that we're asking them, anything that further bars them from using any cigarette, we check that as well, along with the age verification done a second time from our side, from Queen Mary's side. And there's weekly follow-ups done. If the patient complies, then there's weekly supply of e-liquids posted out to them as well. Or we usually try to encourage face-to-face appointments so that we can take a CO reading. Now, to ensure that we're not giving out e-cigarettes to people who do not smoke, we're trying to encourage CO readings before they get the delivery of the e-cigarette device and the kit at their place. And then after this, we ensure that there's a 4-week outcome recorded and a 12-week outcome recorded, which then is a separate data reporting done on Swap to Stop specifically. The next slide. Right. So this was just this started off as an innovative way to bring in more people to quit smoking specifically. And we have also seen that a lot of people find it helpful with an e-cigarette to switch or to quit. And sometimes even if people do not want to quit, but they want to reduce, it has drastically helped them. And even there are some people who sign up saying, I just want to reduce, but eventually, unbeknownst to them, they end up quitting smoking a cigarette as well. As we've had a lot of referrals coming through Swap to Stop, thankfully, touch wood. Till date, we've received 820 referrals, and this table just denotes a certain KPIs that we keep a note of that we've mentioned before, and the number that we have received in there. Because we have also received a lot of referrals, and there might not be people who would want an intensive support of an advisor, the behavioral support combined with it, we kind of split our clientele based on the support they require and they request for. So it can be an intensive support, meaning we would give them a call, or we would get in touch with them, or we would meet them, say 2 days a week. Or there's also a weekly meeting that we might do, or if they would just like contact through video calls, we do that as well. So there we also offer the choice of, if they have any difficulty in setting up the device, we also offer video calls if they're not able to come into the clinic to show them how to set up the device and fill in the liquid. And there's apart from this, there's also a light touch approach, meaning that there are clients who mentioned they would not like a weekly call. So with them, we might either do a call once in 2 weeks, or meet them once in 2 weeks, or just check in with them at 4 weeks to check their 4-week outcome, and then further down their 12-week outcome. So from the Black, Asian, and minority ethnic community, out of 820 referrals, we've received 406 referrals from BAME. We've had 419 referrals from male smokers, 102 from routine and manual, which is something we're still working on to increase. Hopefully, we could reach, say, maybe bus drivers or train drivers specifically, because that would be a large cohort that we think we can work with. We've previously worked with construction sites as well, where we've held outreach events there and registered clients. With long-term conditions, we've received 197 referrals, and for mental health, we've received 327 referrals till date. With this is a number of all 3 boroughs put together. We will come down in the following slides. You'll also see the outcomes for each specific borough split up. Right. So this is our quit rate so this is for the last 3 quarters, sorry, the last 4 quarters over 1 year. That's why you see 4 boxes. I'll just concentrate on the last box for each table. So the first one is for new clients who have used an e-cigarette. So along with the web access, we also ensure that e-cigarettes are usually our first line of support, even for referrals that we receive through, say, NRS, meaning acute hospital referrals or referrals from CGL, substance misuse, any referrals that come in, we ensure that we utilize the Swap to Stop offer there as well. So Swap to Stop includes the web access and also just general referrals from all other sites. So for Newham, we've had 635 people set a quit date using an e-cigarette, out of which 369 have quit. So we've seen a 58% quit rate at Newham using e-cigarettes. Moving on to Tower Hamlets, we've had some good amount of referrals as well that have come in through the web access. With the quit rate, 1,167 people have set a quit date, and wherein 657 people have quit. So that's a 56% quit rate. And the last table is for Waltham Forest. That's our third borough, where 191 people have set a quit date and 108 have actually quit. And that, I think that's a 57% quit rate right there. Let me just check again. I'm a little weak in maths.
Just conscious of time, so just going to give you about 2 more minutes, if that's okay.
Oh gosh,
yeah, that's fine. Okay, so that's a 56.5% quit rate right there for Waltham Forest.
Okay, so if I sort of talk about some of the partnership work that we have and stakeholder collaboration. So we've got target population groups. So we then reach out to GPs, mental health trusts, the hospital trust, and we ensure that we have pathways. One of the new things that we've done is working with Change, Grow, Live, substance misuse, and young people's organisations to try and target our young people and also people with mental health and substance misuse, targeting family hubs and working with public health colleagues and local faith organisations and community pharmacies. So we deliver training and referral pathways. So once we've made contact with stakeholders, we offer very brief advice in smoking cessation training and deliver and try and sort of make a referral pathway specific to that organisation, ensuring there's data sharing agreements in place. And they have a sort of secure email to refer patients to. We have annual STRP updates with Professor Peter Hayek and a level 3 2-day training that we offer for stop smoking practitioners. Anyone that joins the services has an internship with us, particularly postgrads at QMUL. We can train them on the job and provide supervision to then sort of have stop smoking practitioners when vacancies open up. So these are some of the examples of the pathways that we create. This one is with BARTS, sort of our treatment program and the inpatient pathway that's delivered by the inpatient stop smoking team. And this is how we sort of, work out a plan and how we connect. This is one for smoking in pregnancy, which is our sort of one of the really good projects that we've done and, really got some good results with quit rates and partnership work within the trust. So I'll share some results with that. This is a pathway with CGL. So we want to know what's going on at CGL in terms of clients that are coming in who smoke. And then we have an inpatient an advisor that's co-located with CGL once a week, that's able to pick up referrals and offer behavioural support on site, which then makes it easy for the service users to access our service. So it's similar to working in inpatients. We have advisors that are co-located within the trust that work with the teams there. And then we have, with pregnancy, we have a tobacco dependency midwife that our advisor connects with. So some of the pregnancy results will be coming sort of further along. So targeted outreach. So we have 4 annual campaigns, sort of various areas within the borough. So some of the examples, New Year campaign with Newham, we sort of work very closely with Newham Public Health to deliver a sort of a service under the Well Newham umbrella. So our advisors are out in the community with an outreach stall and engage with people. Again, this year's No Smoking Day was outside Stepney Green Station for Tower Hamlets. And we had very good, 30 sign-ups. And then you've got the Ramadan campaign. So tailoring campaigns to different groups. And we've done Ramadan campaign for a very long time. And so we've got materials that are sort of branded for each borough. So this is for Tower Hamlets, and then the Tower Hamlets launch for Ramadan at East London Mosque. And then we have Waltham Forest. We have the Waltham Forest branding for Ramadan, and then we're outside mosques talking to the congregation and handing out flyers. We have social media assets, posters and digital screen graphics for all of the boroughs throughout our campaigns. Outreach events and feedback from the Stop Smoking Service. This is a particular work that we did with a construction company here on the left, Hartley Construction in Canning Town, to try and increase routine and manual smokers into the service. Then we have Forest Gate Library and Tate and Lyle Factory to try and sort of target that particular group. Our service results were very, very successful. We've exceeded our Tower Hamlets targets by 10 this year, last financial year. So we're, very, very hardworking. We deal with a lot of people, a lot of smokers. Our Newham service is doing really well over the last financial year as well. So we're getting better every year. And again, Waltham Forest, we've done really, really well in our we straddle 2 financial years in Waltham Forest. So this is our sort of last financial year result. So it's 61%, which is really, really good. And then examples of priority group outcomes. So this is the pregnancy results that I wanted to show you about the co-location with our advisor. So the partnership work, you can see that the quit rates are really, really high with pregnant women that access the service. I'll make some of these PowerPoints available later so you can sort of have a look in detail. So we have had a very good sort of targeted approach with pregnant women, which has been really good. And then we do surveys with our community. So we need to understand the barriers and sort of the proposed solutions. So translating materials, providing different support models like touch intensive support, video calls, all of that's informed by service users. Reaching the population where they are, so targeting mosques and schools, again through training and doing workshops, and then expanding our services to holding clinics at GPs, libraries and family hub sessions, so making sure that the advisors are available within the community. And finally, so the last slide, thank you for listening. This was just an overview of everything that we do. And so just to summarize, local needs are very important. Study your local service specifications, tailor the service and the evidence base to support high priority groups, and also collaborate with local organizations, get pathways set up, try and sort of tailor things. And then innovation, using vapes with all target groups, obviously, not under 18s, but, being innovative always helps to increase numbers into the service. And then, of course, data management, having, good data analysis and, provides a quality service, and also, internal governance, safeguarding, all of those things are quite important. And I leave a case study here for you to look at after this presentation. So thank you very much for listening and your patience. Thank you.
Thank you both. That's really great and really comprehensive. And I think the chat reflects how relevant and practical that presentation was in terms of lots of questions for you for the Q&A, which we will save for that session. But really, thank you. That was really thorough and really good to see what you're doing, and the kind of outcomes right there next to each other is really, really helpful. We've got our next presentation, which is Zainab, who is an intern at OHID, and has been working on, also a PhD student at University of Leeds, and has been working on some literature reviews around smoking and behavioural science, and we thought would be really helpful here. So you've got 10 minutes, Zainab. I'll pass to you if you want to share your slides. If not, Emma has them as backup. Thank you.
Perfect. Thank you, Sterling and Emma. I'm just going to share my slides. Can you...
Yep, we can see that.
See that? Okay. Can you see that now?
Yes.
So it's full screen.
Perfect. Thank you.
Yeah. Perfect. I won't be able to see anyone, but yeah, hopefully it will. If I go over 10 minutes, please feel free to stop me. Hopefully not. But
Will
yeah,
do.
thank you.
Thanks.
Thank you for introducing me. I'm Zainab. I'm currently undertaking a 3-month internship in the Behavioural and Social Sciences team at OHID. Outside of which Sterling said, I'm completing my PhD in health psychology at the University of Leeds, which focuses on intervention optimization. And today I'll be presenting some of the findings from a literature review that I've been working on during my time here, which is about increasing motivation to quit smoking in entrenched smokers. And just to say that this work was commissioned by the Behavioural Programs Unit to help inform some of their marketing campaigns around smoking and vaping. So as a result, a lot of the recommendations I'll be making are tailored for a more individual level social media style campaign, rather than making more general policy or population or community level recommendations for behaviour change, which we know are also really, really important. So the OHID literature reviews, we aim to answer 3 key questions, which my colleague Mia Coop, who's now left the civil service, she was working on the first 2. But for this one, I'm going to be looking at increasing motivation to quit smoking in those who don't want to quit. But if you are interested in the first 2, do send me an email after, and I can share the results of that with you. So we conducted a rapid review using the UK Health Security Agency systematic literature search, as well as Google Scholar and backwards and forward citation about entrenched smokers, as well as drawing on broader behavioural science, evidence and theory. So as a precursor, in this review, an entrenched smoker is defined as persistent smokers who express no motivation to quit. But research shows that motivation to quit smoking is consistently associated with making quit attempts and in successful cessation. However, most cessation programs are only accessible to smokers who actually say that they want to quit or do want to quit. So there's a key population who are not accessing support and thus, to our knowledge, are not making quit attempts. And entrenched smokers are a minority of current smokers, because the majority of smokers do indicate that they want to quit maybe at some point, but they still contribute a significant cost for the NHS, so which is really important why we focus on this population. So there were 5 main themes in the literature review, which I'm going to present in turn. So firstly, we found that many entrenched smokers felt that they ought to quit rather than wanted to. However, as I mentioned, an intrinsic desire to quit smoking is actually associated with future quit attempts, whereas duty, a feeling that one ought to quit, is not. And in behavioural theory, the desire to quit is key to producing behaviour change, and that's across lots of health-seeking behaviours. So even if an appropriate of the situation is present, for example, like believing that, you know, I have a duty to quit for my health or for my family, the desire to actually quit, like an intrinsic desire to actually want to quit, must be strong enough to compete with any kind of competing impulse to smoke. So based on this, campaigns which only focus on emphasizing the extrinsic duty to quit smoking, such as for health or family reasons, are unlikely to result in any successful behaviour change for this population specifically. And in fact, we've seen from the evidence that it's more likely to increase defensiveness. If you kind of keep reiterating the same things that they keep hearing, they don't really want to hear it. If they know it all, that's not really, that doesn't really seem to be very effective in this population. Instead, campaigns should work on fostering intrinsic motivation, which can help individuals feel more in control. It kind of encourages a sense of autonomy over their behaviour. And theories of motivation suggest that campaigns to kind of foster intrinsic motivation should present smoking as not being enjoyable as they might think, how to associate quitting. The campaign should associate quitting with feelings of anticipated pleasure or satisfaction, or anticipated relief from distress and discomfort. There are also a range of other things in the review, which you can kind of, if you want to have a read of later, which focus on how we can increase intrinsic motivations, but I just don't have the time today, fortunately. So for example, presenting media that presents successful quitters experiencing positive life changes and no longer experiencing downsides of smoking, without kind of emphasizing, oh, this is your duty to do this. Just kind of presenting it passively is more likely to be effective. So the next theme was social identity. So smoker identities appear to be very strong in this population, with entrenched smokers reporting that they really enjoy being a smoker, particularly the social benefits. For example, they highlighted in many qualitative studies that social disapproval might be a factor that would increase the motivation to eventually quit smoking. So to address this one, we could emphasize that the social aspects of smoking can actually still be maintained without smoking cigarettes, but instead through vaping or e-cigarettes, and also highlighting that vaping is becoming more kind of socially acceptable, more popular than cigarettes. So, for example, a social media campaign could present images of an isolated smoker amongst a group of vapers, and really kind of hit on those kind of subjective norms around smoking and vaping. And we could also highlight that the evidence does show that most current smokers do want to quit. So within their peer groups, these entrenched smokers are more likely to be a minority. So again, hitting on those kind of subjective norms. So the third theme was the awareness of the negative effects of smoking. So this kind of relates back to this kind of desire over duty. And many entrenched smokers we found downplay any negative effects of smoking and can account for this cognitive dissonance by justifying their behavior, for example, with self-exemption. So saying, smoking is worth it, or those health problems are not going to affect me. They don't affect me now, they're not going to affect me later. So to address these cognitive biases and skeptic beliefs, we can aim to make the information more salient to specific groups, such as introducing real new facts, not kind of reiterating the same things that campaigns have kind of used in the past, or as well as kind of highlighting more pertinent groups, concerns for each group, which you can do with social media campaigns. You can kind of have more targeted adverts. So for example, for younger people, they might react less to messaging about premature death compared to older populations, but campaigns which highlight the way that smoking can affect immediate physical appearance is likely to be more important. The fourth finding was about self-efficacy. So self-efficacy describes an individual's belief about their capability to control their behavior. So in smoking, it's having the conviction that you're able to actually quit smoking. And self-efficacy has been shown to positively predict the intention to quit smoking, whereas low self-efficacy has been associated with persistent or entrenched smoking. So self-efficacy in this group is quite low, essentially. And these findings suggest that increasing self-efficacy amongst entrenched smokers about their ability to quit could be a potential target. So the literature suggests that one potential way to improve self-efficacy is to focus on enhancing positive emotions and optimism around making quit attempts rather than triggering any guilt or shame or fear. And smokers who make a failed quit attempt are more likely to quit smoking in the future than those who have never made a quit attempt. So messages which positively encourage any attempt to quit, even if they relapse, could help improve self-efficacy and in turn a desire to quit. So Stoptober type campaigns which aim to encourage short-term quit attempts could be useful here. And kind of suggesting realistic and more achievable goals, as this provides more structure and minimizes any perceived incompetence, which again is related to self-efficacy. And the final theme was about cost. So entrenched smokers highlighted that financial concerns could be a factor that would likely increase their motivation to quit. Obviously, I'm not going to be making policy recommendations about the cost of cigarettes, but marketing campaigns could continue to highlight the financial. Sorry. I'll keep going. So marketing campaigns could continue to highlight the financial benefits of quitting smoking, especially during the increased cost of living. But ensuring that this is, through behavioral science literature, we know that ensuring that this is really specific and quantifiable is more likely to be seen as credible rather than just saying, oh, you could, save money if you quit smoking. If, using economic projections and statistics, saying specifically successful quitters save around this much per month, and you could consider comparing this figure to valuable items as well. Additionally, one could highlight that reusable vapes are significantly cheaper than cigarettes in the long term, which can also help encourage the switch amongst this group of entrenched smokers. And so some final additional considerations. So research shows that entrenched smokers are more likely to be from lower socioeconomic and ethnic minority groups and experience poor mental health. So these complexities and vulnerabilities should be accounted for when developing interventions to ensure that health inequalities are not widened. Also, I've talked a little bit about switching from cigarettes to vapes. So campaigns which encourage a switch from cigarettes to vapes could help increase motivation to quit because the strong perceived benefits of smoking amongst this group can still be maintained through vaping. And a recent study showed that smokers not planning to quit actually had higher odds of quitting smoking when they took up daily vaping, which is quite similar to what the previous presentation was talking about. And early research suggests, however, that entrenched smokers do hold some negative views about e-cigarettes and vapes, which should be addressed, and some more information about that is in the opioid literature review. Question 1 that Nia worked on. And just the final thing is, as I mentioned at the start, there's a focus on this aspect because it was for a marketing campaign on individual level factors. But we know that to address complex health behaviours, public health promotion interventions, we need to shift away from just kind of focusing on individualistic epidemiology and invest resources into modifying external factors as well. So, for example, creating a supportive environment. So thank you so much for listening. I'm leaving civil service on the 16th of July. So if you've got any questions, you can email me. But if after the 16th of July, feel free to email Anna, who is the head of the Behavioural Social Sciences team. There's some references and key papers at the end of the presentation, which I hopefully can share the slides with. And just to say as well, I'm really sorry I didn't mention to Sterling, but I only work till 4 usually. So I'm going to stick around till 4:30 today to answer any questions in the chat. But if you've got any questions, after that, I won't be able to attend the Q&A. Please feel free to email me. I hope that's okay. Sorry for not mentioning that before.
No worries, that's fine. Thank you so much. That was really comprehensive in a short amount of time and really actually easy to digest, which is really great. And I think really helpful to think about that kind of cohort of people. And we saw that in the last slide of that being a priority group with multiple TIMs or things like that. So really appreciate that presentation and the slides thereafter. But if people do have a question, if you want to put it in the chat, and then maybe Zainab can respond via the chat for now before she logs off. Thank you so much. That's really helpful. And last we have Dr. Jamie Hartman-Boyce, who is the Assistant Professor of Health Policy and Management at the University of Massachusetts Amherst, and I think brings a really, really interesting insight alongside these last two presentations. So having worked with the Cochrane and led a number of research programs around both smoking and vaping, and worked on the 2021 review, which focused on the behavioural interventions for stop smoking, I think it gives us that kind of academic perspective of what's the evidence saying, what's most effective, and like where can you go and find that research to inform either service specs or your kind of service design and the way you deliver services if you work directly in the services. So yeah, well, thank you so much for coming, and over to you. We have your slides, or you can share them, whichever you'd like.
Thank you so much. I'll try sharing them, but if anything goes wrong, it's nice to know that you have them too. So hopefully you can see those slides okay. Let me know if not. Great. All right. So hi, everyone. Thanks so much for having me here today. My name is Jamie Hartman-Boyce. I have my assistant professor role at UMass Amherst, and I also spent a number of years working for the University of Oxford before that. So I'm back in the States now, but very familiar with the British context. In terms of acknowledgements and disclosures, just some research funding listed up here from independent organizations. I don't have any conflicts of interest to declare. And what I'll talk about today is a little bit about me and the work I do with Cochrane. I'll talk about the evidence that we have for some behavioral interventions for stopping smoking, then a little bit of the evidence on how those might compare with each other, and end by briefly talking about pharmacotherapies and e-cigarettes. And I'll be around for the Q&A, and also I'm very happy to take emails if questions come up later, because there's so much to cover in this space, and you'll be relieved to hear that I'm definitely not going to try to cover all of it today. So for the last 12 years, I've been working for the Cochrane Tobacco Addiction Review Group, and Cochrane is a global nonprofit organization that covers all topics within healthcare and public health, so not just tobacco. Tobacco is one of 52 review groups historically, and they exist to gather and combine the best evidence from research in order to determine the benefits and risks of treatments and interventions. And the way that we do this is through systematically reviewing the available evidence with a really strong emphasis on quality assessment. So when we set out to do a systematic review to say, for example, does behavioral counseling help people? Oh, sorry about that. Don't know what happened. Does behavioral counseling help people quit smoking? We'll go out, we'll bring all the evidence together, we'll combine it statistically, but we're not just interested in the average effect. We're also interested in how much can we trust this evidence in front of us. We do this following a very large handbook of methods which are considered gold standard. They're very rigorous. We aim to be really transparent and unbiased. And the role of Cochrane is to do this to help people improve their knowledge and to help them when they're making decisions have the best available evidence in front of them. And Cochrane, our job is not to say this is what you should or shouldn't do. It's to say you're making difficult decisions. Here's the best available evidence, because we know that very few people have time to review every trial that's ever been conducted in a certain area and make decisions from there. I do want to point out that Cochrane reviews are free to access for anyone in the UK. The government pays for access to them. So if you want to learn more about any of the reviews that I'm going to talk about today, or indeed Cochrane reviews on any other topics, they should all be free for you to access online. So Cochrane reviews are very large documents. Very few people read them from beginning to end, including, I think, sometimes the people who write and edit them. But there are certain key things that are really at the top of a Cochrane review, if you go into it, that are worth knowing about and looking for when you're thinking about, okay, how much do I trust this evidence in front of me? The key things that I would tend to look at if I were looking at a Cochrane review or any other systematic review for that matter would be how many studies are included. The more studies we have, the more certain we can be of their results. How many participants are included. The more people we have in these studies, again, the more certain we can be of results. What is the evidence of benefit? So what is the evidence that a certain intervention works? And for us, within the Cochrane Tobacco Addiction Group, we mean how many people are abstinent from smoking at 6 months or longer. If we're looking at ways to help people quit smoking, that's really our benchmark, because we know that quit rates, unfortunately, can really fall quite steeply over time due to relapse. I'm also always looking for any evidence of harm in any of the interventions that we are testing. And finally, one of the things to be looking for is how certain is the evidence. So this is about not what does the evidence show, but how much can we trust what it shows. In Cochrane, we do this using something called the GRADE framework, which you will see in other places as well. So guideline developers like NICE and the WHO use GRADE frameworks. Other journals, for example, the BMJ uses GRADE, and it's a really simple rubric that ranges from high certainty all the way to very low certainty. So we judge each of our findings using this GRADE rating. When we say a finding is of high certainty, it means that we think further studies might come along, but they're very unlikely to change our conclusions in any meaningful way. So if our review finds something works and we have high certainty that it works, then we think that further studies are just going to keep on showing that it works. This goes all the way down from moderate low to very low certainty. And at the bottom with very low certainty, it means that really we don't trust our conclusions at all. Another study could come along and completely change our understanding of how the intervention might work. So what I'm going to do for the rest of this talk really is go through the evidence that we have from Cochrane reviews that look at ways to support people in quitting smoking. What I'll start with are individual reviews of different behavioral treatments for helping people to stop smoking. And it's worth saying that most of these are comparing these interventions to a minimal intervention control, which might be a self-help leaflet or very brief advice only. So to start off with, when we looked at individual counseling given face-to-face to help people quit smoking, in the latest version of that review, we had just under 50 studies in around 20,000 participants. And we found that individual face-to-face counseling increased the chances of people quitting by about 40 to 70% overall. There was no evidence of harm from individual behavioral counseling for quitting smoking, and our certainty of the evidence here is high, which means that we think it's very, very clear that counseling people on how to quit smoking helps them quit smoking and helps them stay quit at 6 months or longer. Group counseling, we also have evidence that increases the chances of quitting, but it's a little less precise. We don't have quite as many studies and quite as many participants. Again, we have no evidence of harm, and here we have moderate certainty evidence that group counseling given face-to-face can help people quit smoking as well, increasing the chances of smoking here by around 50 to 230%. And that's what I mean by being a little bit imprecise on that estimate based on the evidence we have available. One thing that is particularly topical at the moment, I feel like it's very accepted that individual and group face-to-face counseling work to help people quit smoking, are financial incentives. And what we mean by these are some sort of financial reward, usually in the form of some sort of gift voucher to a shop, for example, that people get if they are biochemically validated as being abstinent from smoking. So if they show up to a 4-week appointment and, for example, their carbon monoxide is below a certain level, then they'll be given a financial reward for that. We have very high certainty evidence that this intervention also helps people quit smoking. And a lot of these studies are adding financial incentives on top of intensive support already. So one arm might be getting counseling only, and the other arm might be getting counseling and financial incentives to help them quit smoking. And what we see here is that there's very clear evidence that this works, but the thing that has traditionally, I suppose, been a barrier to rolling this out are societal attitudes around this. So there have been a lot of successful schemes in the UK where people who are pregnant are given financial incentives to help them quit smoking, but there have been some barriers around doing this in the general population. But we know it works in the general population. And it's worth pointing out that this isn't because people essentially don't want to quit smoking and then get given a financial incentive and they're like, oh, I guess it's worth it after all. We know that because the way addiction works in the brain, and particularly nicotine addiction works, and the neurochemical and biological pathways that are related to reward, we know that giving people another type of reward can disrupt some of those signals of reward that they might get from smoking a cigarette. So this is actually working on a biological and neurological pathways to help interrupt the pathways that we see with smoking addiction. We're updating this review at the moment, so we hope to have an update to this out in the next few months, because this remains a really active area of research, but the new update is also going to find high certainty evidence that these interventions work really well. So just a plug for those. And what we don't have is any clear evidence on whether the amount of the incentive matters. We don't have many studies that are testing higher versus lower incentives, and we have studies that are offering really not very much money at all, and some that are offering quite a lot more, and all of them find that this is effective, which talks to you, I think, a little bit about the fact that just offering this incentive is helping people rewire their brains to move away from nicotine addiction. So if we look at some more remote-based interventions, we have moderate certainty evidence that text message-based interventions help people quit smoking. Again, pretty imprecise estimates there. The range is that they increase the chances of quitting by 19 to 200%, but we're getting more and more evidence in this space as well around mobile phone interventions helping people quit smoking, and app-based interventions as well. And often these are offered as an adjunct to face-to-face support. We have a lot of studies showing that telephone counseling helps people quit smoking, particularly proactive telephone counseling. So what we mean here is not just access to a quit line that someone could call if they wanted to, but regularly scheduled calls where someone will call up someone who smokes and offer them counseling and advice on how to quit smoking. And we have moderate certainty evidence that those increase the chance of quitting by 20 to 60%, with no evidence of harm there either. So those are kind of our main forms of behavioral support with really clear evidence of effectiveness. We have a lot of reviews on a lot of types of behavioral support, and I'm happy to answer questions on other types as well. I did want to make the point that what we've also looked at is what happens when you add behavioral support to pharmacotherapy, because we know that probably the best way of helping someone quit smoking is to have access to both behavioral support and some sort of pharmacological or e-cigarette intervention. And what we find is that if everyone in a study is receiving pharmacotherapy, adding behavioral support on top of that increases quit rates above and beyond what you see from the pharmacotherapy alone. It goes the other way too. So if everyone in a study is receiving behavioral support, offering one group pharmacotherapy, that group will have higher quit rates as well. So ideally what we want to be encouraging, where it's feasible for services and where it's feasible for participants, is that people have access to both behavioral and pharmacotherapy and are using them together, because we know that they have synergistic effects. Now, these, as I mentioned, were all reviews which are comparing an intervention to very little support. But how do these interventions stack up against each other? How do they compare to one another? This was a question we were really interested in asking and answering, and we knew a lot of policymakers were really interested in too when they were thinking about having a limited pot of money and where that money might go in terms of behavioral support. So a couple of years ago, we published an overview of systematic reviews in something called a network meta-analysis, looking at the different components and different types of behavioral support offered for smoking cessation and how they stacked up against one another. We evaluated over 30 different components as part of this review, including the focus of the intervention, the people delivering the intervention, the ways in which the intervention was delivered, the content of the intervention. I won't go through all of those today, but there were a couple that I wanted to pull out to highlight. The first of these was the focus of the intervention. So we included over 300 studies in this review, and we categorized them as focusing on how to quit, so giving service users advice on the best tools to help increase their chances of quitting smoking, how to deal with urges, etc. Or having a focus on why to quit. So really focusing on motivating someone to quit smoking, for example, talking about health harms or talking about the financial rewards of quitting. And what we found was that the interventions that focused on how to quit, so giving advice to people and practical support on tips for quitting smoking, were more effective than those which were focusing on the reasons for quitting or focusing on the reasons why to quit. So we had moderate certainty evidence that interventions focusing on how to quit, as opposed to not focusing on how to quit, increased chances of quitting from 1 to 40%. Whereas when it came to the why to quit studies that were just really focused on these are the reasons why you might want to quit smoking, we saw no evidence that those increased the chances of quitting smoking at all. That was low certainty evidence, but it's not particularly surprising if we think about the fact that most adults who smoke, particularly in the UK, absolutely know that smoking is expensive and it is bad for them. We know the majority of them want to quit. A lot of them have tried to quit before and it hasn't worked for them. So they might not need someone telling them more about why they should quit smoking. They might benefit more from practical advice about how to do that. When we looked at evidence on selective types of behavioral support, we found evidence that was really consistent with our individual reviews, where counseling, face-to-face counseling to help people quit smoking, and guaranteed financial incentives both had high certainty evidence of increasing quit rates at 6 months or longer. I just wanted to highlight here one additional type that did not have good evidence of helping, and that is what we referred to as financial incentives that weren't guaranteed. And a less academic way of thinking about this, and a less clunky way, is kind of competitions. So there were a bunch of studies which tested, well, okay, we know if we give people who are abstinent gift vouchers, they're more likely to stay quit. What if instead we incentivize them by entrance into a raffle or a prize draw or some sort of competition like that? Those would obviously be cheaper to provide because only some people are going to get the reward. Those, interestingly, had no evidence of benefit at all. So where the reward wasn't guaranteed if you were smoking abstinent, that didn't seem to help in any way. So that's just a cautionary note, and I think probably has something to do with some of the biochemical stuff that's going on around knowing that if you don't smoke that cigarette, there is another type of reward coming your way, as opposed to the kind of chance that there might be a reward coming your way. I wanted to finish off by saying that last year we came out with a similar review, except instead of comparing all the behavioral interventions together, we compared pharmacological and electronic cigarette interventions for smoking cessation to see how these stacked up against one another. And as I mentioned, we know the most effective things for helping people quit smoking are combining behavioral and some sort of pharmacological support. And I would lump nicotine e-cigarettes in there as well. We included data from over 300 trials and over 150,000 participants. What you're seeing here is a forest plot, which is a graphical display of the results of a meta-analysis, which is what happens when we combine data. There is no need to look at this in detail, but it's there for any of you who are interested in forest plots. The main message here is that 4 types of intervention emerged as the most effective. Those were the nicotine receptor partial agonists, cytosine and varenicline. Those are medications that are available on prescription only, and both have had their own issues with availability in the UK. So someone would need to go to their GP to get prescribed cytosine or varenicline. And nicotine receptor partial agonists work by kind of blocking the rewards that you might get from smoking a cigarette. Nicotine e-cigarettes, which are obviously available not on prescription, were found to be equally effective as the nicotine receptor partial agonists that were available on prescription. And combined nicotine replacement therapy, nicotine patch, and a shorter acting form such as gum or lozenge were possibly as effective, possibly slightly less effective than those other 3 types of support. But we know that a lot of people are going to be accessing nicotine replacement therapy because it's easier to access. You can get it from a pharmacy. And it's worth saying that people will really increase their chances of quitting if they're using 2 forms of nicotine replacement therapy at once. We know there's really clear evidence that that's much better than just using a patch or just using a gum. Some people might need some encouragement to do this because they might be concerned about having too much nicotine. But in fact, if you're trying to quit smoking, you need sufficient levels of nicotine. And we know that the nicotine that's delivered by a nicotine replacement therapy, whether it be patches and gum, isn't delivered into the bloodstream in the same way that nicotine from a cigarette or an e-cigarette is, which is why you really want to think about maximizing the delivery if you're going for nicotine replacement therapies of the more traditional forms. We didn't see any clear differences in serious adverse events between these 4 most effective interventions. Bupropion, which is also a prescription drug used for smoking cessation, does have more of a serious adverse event profile and is slightly less effective, so tends to not be used quite as much. But particularly with nicotine e-cigarettes, it's of course worth saying that most of these studies are not super long-term, so a lot of them are only following up participants to 6 months to a year. And they're testing devices that have been approved for use in this setting. So not all nicotine e-cigarettes are going to be the same in terms of their safety profiles. So that is it from me. I'm really happy to take questions. I'm really happy to take emails. There's so much more detail I'd be happy to share if useful.
Great, thank you so much. That was so helpful and really nice to see it all in one place and kind of be reminded. And I think exactly what we're hoping to do is just remind people that all the evidence is there and it is digestible in a way. And hopefully the slide deck kind of gives you an entry. I know going and pulling up all of the reports and reading academic literature is not always easy or fun. So this is just a really helpful way to get it started and think about the kind of all the options that you have and how it might work, and really helpful. We do have a number of questions in the chat for everyone, and I'm not sure how best we want to do this. We might want to kind of rotate between questions and speakers and give people a bit of a chance to think about them. If you think that's best, and unless you have a better idea.
Yeah, I was thinking if we bring back Shamsia and Janveer, and we can sort of run through the questions in the chat and then open it up to the room if that works for everyone.
Sounds good.
Shall I start reading through some of the questions and bring those up? Okay. So Elliot Smith asked if there was any examples about how you reach your target groups and how you sort of change you calibrate your offers to meet their needs. Now, I think that question went up slightly before you put some of those slides up in the chat. I just wondered if you wanted to summarize some of that information quickly for those that missed it.
Sorry, Janvi, did you?
Yeah, that's fine. So I think one of the first things that we do is we try to organize outreach events at places where we can reach specific target groups. So in our slide, we'll share our slide as well. We've held outreach events outside mosques, and specifically we've done a lot of it during Ramadan, because that is a period where they strongly do not smoke, and we do not want them to open their fast because they have not smoked for an entire day. So that's one of the examples. We also have done outreach events at construction sites, reaching out to routine and manual workers. We are in conversation now to reach out with bus drivers. We've done at depots as well to reach that specific group. Apart from that, and just to expand the service, apart from the areas that we have already done, to reach people whom we couldn't reach, that's where the web access came into play. For pregnant women who smoke, we have an advisor who also works with the maternity side of things. So they go in maybe once a week, sits in with the tobacco dependence midwife who's located at the hospital, and anybody who comes in, for that antenatal appointment, and we have recognized that they do have a habit of smoking, we try to intervene at places, meaning they're already coming in for a test. Then those are situations where they use to just call in the patient just to do a 10-minute or a 5-minute conversation to talk about how it can actually help them and the baby as well. So that's just a few examples here and there. Anything else you would like to add, Shamsia? Or if it's good to go, then we can
just
move on.
One thing I wanted to add on substance misuse. So in Waltham Forest, That was one of our KPIs. And so we approached the Substance Misuse Service, CGL, to try and see how they work and how many people that they could refer. So we sort of kind of, link in with their team, deliver VBA in a team meeting. When do the service users come in? How would we approach this? So we decided that we'd have a advisor co-located at CGL. It started off as a remote appointment, then it became a face-to-face appointment just to gauge the numbers. And now sort of every quarter we see around sort of 10 to 15 quick date sets at that particular organization. I mean, the numbers are not huge, but it's a targeted approach, and we do harm reduction, obviously, in that area. E-cigarettes are available. So it's just sort of adding lots of elements to try and reach a particular group.
Yeah, BARTS also has inpatient advisors where they go in and see patients who have been admitted to the hospital. So that's where, again, they get to target people with long-term conditions who, again, get referred to us. We also have advisors from Queen Mary who also support with the BARTS advisors as well. So there are several pinpoints where we work at just to try and cover as much as we can.
Fabulous. Thank you so much. And there was a few questions around your use of vapes and the way you do that. So I'll actually group those together to make it a bit easier. The first question was around why you exclude COPD patients from your swap to stop offer. I'll just quickly go through the other ones and then we can see if we can answer them all in turn. The second was around, do you use patches with the vapes or are you using the vapes in isolation? And the other one was around, for people who haven't completely stopped, when do you stop providing your e-liquid supply for those that are still using the vapes?
Right, to start from the top. So the COPD exclusion, it's not a hard and fast rule, but it's more got to do with the extent of their COPD. So if they are on oxygen, so meaning some of the COPD patients also have oxygen cylinders at home, some visit the clinics for the oxygen. I'm not sure entirely of the treatment process, but they also visit respiratory clinics. But apart from that, there are clients who need oxygen and they have those oxygen cylinders at home. So just to prevent, as a safety concern, we would not give out an e-cigarette for them. Maybe start off with a patch or other licensed nicotine replacement products. And if that doesn't work, then the offer is always on the table if everything else aligns as well. And moving on to so we also, an e-cigarette is the first line of support. But if a patient does require intense, so this comes under intensive support, where we can also deliver patches and an e-cigarette as a combination therapy, or patches and any other type of product that sits well with them. If a patch doesn't suit them, we can also try a nicotine gum or a nicotine lozenge. So it's a personalized approach for each patient. They might be on a different combination and permutation of therapies. Usually we have seen a high quit rate with just e-cigarettes, but if there are patients who do not want to use the e-cigarette, then also we do definitely offer licensed nicotine replacement as well. Sorry, Emma, what was the last question?
Yeah, so the other question was, when do you stop providing the e-liquid if that person hasn't completely switched to vaping or stopped smoking?
So we have as we have 3 different boroughs, we have different timelines. So for Waltham Forest, we provide a 12-week program, whereas for Tower Hamlets, we provide an 8-week. For Newham as well, I think we provide a 12-week. So we follow them up for these periods of time, and if they have quit or if they have reduced, then until 12 or 8 weeks we can give out the e-liquids to them, which after that when they receive the kit, they also receive kind of a discount code with it. So after that, even if they want to continue on, say 0% or 1%, they can order it for themselves. And we also share the website link where they can access them.
Wonderful, thank you. I've just got a couple of other questions that came up in the chat around your presentations, and then there's a few questions I want to direct to Jamie, so that we can answer those as well. So again, there was a few questions around your work with patients with common mental health issues and serious mental illness. So it was around first question was around how do you engage with those patient groups, and do you have any specific level of training over and above what you would normally offer for the people that are working with those groups? And also, do you work with SEN groups as well as those with mental illness and serious mental illness?
So I'll address the mental health groups. We work with the Mental Health Trust, who have a stop smoking team. So they support inpatients for a period of time and provide nicotine replacement therapy. And then they also advise those patients within the community. So in that respect, they are co-located with us, and we provide the nicotine replacement therapy and the vapes for the community part of the service that they receive with the trust. So that's one thing that we do with the mental health and SMI groups. The other thing that we do, we get mental health referrals from GPs. So if a patient may come through to us and their medical records, when we do the assessment, they'll say they've got depression or anxiety. So we will then ask them, do they take medication? So that's another way that people come in that display sort of mental health concerns or severe mental health. So what we then do with them is, one of the approaches was to sort of provide an e-cigarette, because we knew sort of over the years from sort of, experience from advisors, was that it was harder to get them to quit using the dual NRT, the combination NRT. So we thought, let's start using e-cigarettes with this particular cohort, because if they get to 4 weeks and they're using the e-cigarette instead of smoking, that was a win. That was a quit outcome, and the CO reading, verified them as a quit. So that's a sort of a different approach that we've used with the mental health cohort. We've also sort of going forward, we're going to be targeting them outside of the trust. So people who are living within the community with mental health, we will be targeting them through GP practices. Plus, when we go and do our outreach events, we will ensure that we are covering this population by asking the questions. And in terms of training, do we provide the training? Now, we don't specifically provide training around mental health and smoking. This is something that the trust has been providing, but obviously when we go forward, we would be ensuring that we have the relevant expertise to do that in terms of and also the NCSCT have an online module for mental health, which all of our practitioners have done. I hope that answers the question. A bit of a long-winded answer.
Fabulous. No, thank you very much for that. And obviously, in the interest of time, we've got a few questions for Jamie as well. So I just wanted to address those. So lots of information, Jamie, about the evidence behind the behavioural support and the pharmacological services. There was a few questions around the financial incentives and the studies that you'd looked at around that. So the first was, is there evidence that it works to sustain the quit in the long term? And there was also a question around the size of the incentive as well, and does that influence the success of the outcome?
Those are both excellent questions. So there is evidence actually that the increased quit rates continue even after the incentives stop being offered. So we did some further analyses to look into that to make sure that it wasn't just that people were quitting more and then as soon as the incentives stopped, everyone returned to smoking. That wasn't happening. Actually, those seemed really steady in terms of the effectiveness rates. They seem to continue even after the incentives finished. In terms of the amount of incentives, we don't have an answer to that yet. There aren't very many trials out there which are directly comparing incentive amounts. So the best we can do is kind of look across trials to try to make sense of it. But that's not easy to do because different levels of incentives mean different things in different contexts and places. So there's no clear evidence that kind of bigger is better necessarily, although it kind of feels like it should be. And we're planning a little bit more work to look into that, but at the moment, can't answer it actually. We just don't know.
No worries, no worries. And there was another question around the financial incentives. Is there any evidence that shows they work better in different population groups? So obviously there's a lot of evidence around it working in pregnant smokers. Is there any evidence that it works particularly better in different groups of smokers?
No, so the groups that it's been most tested in have been kind of like general populations of people who smoke, pregnant women who smoke, and also there is an increasing subset of studies in people with other substance use disorders, and it seems to work just as effectively in those populations as it does in the general population as well, which is good to see.
Wonderful. And there was one final question. Was there any studies that you'd looked at around relapse prevention and anything that you had around that at all?
Yeah, so a colleague of mine actually leads the Cochrane review of relapse prevention interventions when it comes to helping people who've successfully quit smoking stay abstinent. And that is, through no fault of his, I'm an author on it as well, a frustrating review simply because there really is no clear evidence, particularly around behavioral interventions, having any clear effects there. I know that he was involved in developing the NICE guidance on this as well. And it's not necessarily that things have been extensively tested and that nothing works. It's that there's a lot fewer trials looking at preventing relapse than there are at helping people quit smoking. So I think we need more work there. And I think one particular area where we're in dire need of more evidence, which I think there are trials looking at this now, are for people who quit smoking through using an e-cigarette. The NICE guidance currently is then they should stop using an e-cigarette as soon as they feel they're no longer at risk of relapse to smoking. But I don't know how that is determined or how anyone can say for sure they're no longer at risk of relapsing to smoking. So we tend to see trials and guidance recommend that people keep using, for example, their nicotine e-cigarette or their nicotine replacement therapy for as long as they feel they need to.
Wonderful. Thank you. And Sterling, was there any additional questions that you had at all?
No, that's really helpful, and I think really insightful questions as well. I think, yeah, it's just a really helpful hour and a half to catch yourselves up on evidence. So thank you, really, really helpful, and thank you all for presenting and bringing your insights to the group, because I think, as the chat shows, really appreciated and really timely in terms of everyone's planning. So thank you all, and I'm sure I speak on behalf of everyone for that. Great. So we're gonna share the recording at the end of the slide, or once we're done, over email. If you have other questions, I think our colleagues have offered to answer questions over emails, but we will share the slides if everyone's happy, and we'll confirm after this. And then you have those as a resource. But you know, between myself and Emma, we're around to answer questions as well, or point you in the direction of anybody else that can help answer a question from the behavioral science or stop smoking literature. But yeah, thank you very much for your time and coming to join us. And thanks, Emma, for connecting and collaborating with the BSPHN. It's been really good to connect and see how we can help each other.